Good morning. Today is the third series of our RDSN is CME, a type of public awareness campaign. So I welcome Dr. Bijaya Mishra. She is Associate Professor of Biochemistry in Bijaya Institute of Health Sciences, Tehran, and she is fond of this genetics, especially newborn screening, and she has special interest in case of preventive care and in case of this newborn screening and rare diseases and genetic diseases. So today she's enlighten us about the future of the rare disease in Nepal. So I welcome Associate Professor Dr. Bijaya Mishra for her wonderful presentation.
Is my slide visible?
Yes, visible.
Thank you so much, Dr. Rajan. Good morning, good afternoon, evening, and namaste, everyone. I am Dr. Bijaya Mishra, a clinical biochemist working at BP Koirala Institute of Health Sciences, Tehran, and also a board member of Rare Diseases Society, Nepal. And it's my honor to welcome you all to the third episode of RDSN webinar series, which happens last Saturday of every month. And these webinar series are conducted to spread awareness on rare diseases to the healthcare professionals, medical students, and community health workers. Today, we have a session in which we will connect newborn screening and rare diseases. And before I begin, I would like to briefly introduce Rare Diseases Society Nepal, RDSN. It's Nepal's only umbrella organization dedicated to supporting individuals with rare diseases. And it envisions holistic medical and psychosocial care, encouraging self-reliance and connection among affected families, and with a mission to improve the well-being through enhancing diagnosis, counseling, awareness, and research. And its goal include providing swift and accurate diagnosis, creating networks for patients and professionals, advancing genetic diagnosis and research center, and collaborating broadly to strengthen advocacy and care for rare. Today, I feel deeply honored to be speaking with you all on a topic which is very close to my heart: newborn screening, rare diseases, and the vision for the future of rare disease care in Nepal. I have titled my talk, Every Baby Counts, because truly behind every statistics, there is a baby, a family, and a lifetime of potential. And every child who comes into this world carries within them an untold story, a future full of possibilities, but sometimes hidden within their first days of life are silent conditions. Metabolic disorders, rare diseases that may not show any outward symptoms at birth, yet can profoundly affect their health, development, and even survival if left undetected. So, let me begin with a question. Did you know that with a few drops of blood taken from newborns' heel by a heel prick test within 24 to 72 hours after birth could change the entire course of their life? It could prevent a lifetime of disability or even save a baby's life. It could detect serious but treatable condition before appearance of symptom. This simple test that saves lives of newborn is called newborn screening, and it is already saving millions of children around the world. Imagine what these simple tests saving lives, what it could mean for us in Nepal, where numerous families are left searching for answers long after their baby begins to suffer. So let us see how we can make the vision of saving babies with rare disease a reality. What is newborn screening? So, by definition, it's a population based public health program. And when we say population based public health program, it means every newborn, regardless of background, gets a chance of a healthier future. It is considered to be one of the top 10 most successful public health program of 21st century. And this idea of newborn screening started in 1960s when Dr. Robert Guthrie, who is also now called as the father of newborn screening, he developed a test which could detect rare conditions called phenylketonuria, abbreviated as PKU. And that was the beginning of global revolution in child health. Newborn screening is performed using the dried blood spot card. We call it as a DBS card, which is a filter paper card. And in recognition to the contribution by Dr. Robert Guthrie, we also sometimes call it as Guthrie's card. So a simple heel prick test is done on the baby's heel within 24 to 72 hours after the baby is born, and that dried blood spot card is used to test numerous conditions, some of which are just few highlighted here, like congenital hypothyroidism, phenylketonuria, sickle cell disease, and many more. So when talking about PKU briefly, which was actually the condition from which newborn screening started, it's simply like in PKU, the amino acid phenylalanine is not metabolized properly in the absence of the enzyme in the metabolic pathway, and which will lead to accumulation of these phenylalanine in the blood of the baby, which crosses the blood-brain barrier. And since the level is very high, the phenylalanine in the brain, it competes with other useful amino acid needed for the brain to function properly. And in that competition, when the other amino acids cannot enter the brain, function properly, it leads to adverse outcome like severe intellectual disability. And this severe intellectual disability is permanent in the baby. Had this baby been screened and detected early just by a simple heel prick test, we could have avoided and tested and avoiding the milk-free in phenylalanine milk. This could have saved the baby from such adverse consequence. So newborn screening is designed to detect condition early in the babies before symptoms appear, thus enhancing timely treatment and preventing severe outcome. And the target disease for considering newborn screening, those diseases are serious, they are treatable, and if not detected clinically at birth, it could lead to a very adverse consequence for the baby. So example of the conditions include, again, as I mentioned already, CH, sickle cell, PKU. And looking globally, our neighboring country, India, they have already started, several states has started implementing this newborn screening, starting with a simple disorder like congenital hypothyroidism. So newborn screening, as I mentioned earlier, it started in 1960, and PKU was the first condition to be screened, and now it has been established as a global practice in many countries. And why does it even matter? Why does newborn screening matter? Because many babies, when they are born with any inherited disorders, they appear to be perfectly fine, healthy, and these disorders are not visible at the time of birth. And if they are not detected early, if the babies are not screened, it would lead to devastating condition in the baby, leading to disability, developmental delay, or even death. And with screening, we can ensure healthy growth and normal development in the child, in the baby. So, as mentioned earlier, it is recognized as one of the most successful public health intervention of 21st century. So, talking about the principle of newborn screening, we screen the baby, but the screening is just the initial step. After screening, the confirmation diagnosis should take place. And once the confirmatory diagnosis is done, we treat the baby, and there should be a robust follow-up system in place. So newborn screening is not simply a test, but it is actually a system. It's a program. It's not just you test the baby and it's over. It's a program which needs following up of the baby as well. So how do we define, which conditions to be considered for the newborn screening? How can we choose the disorders out of so many disorders that are there? How do we decide which condition to screen for? So there is a Wilson and Younger's criteria for newborn screening, and the condition that we choose to screen should be an important health problem. We cannot just randomly choose any disorders that we want to. It should be an important health problem, and there should be accepted treatment for the patient with the recognized disease. There is no point in diagnosing something which does not have a treatment. So there should be an accepted treatment, and there should be facilities for diagnosis and treatment available. What if we just screen the baby, but we don't have a measure to, treat the baby? So that should be available, and there should be a recognizable latent or early symptomatic stage for that disease, so that we can catch up the babies at that particular time. And there should be suitable test or examination which is affordable, which is acceptable to the population, and the natural history of the condition that we plan to screen should be adequately understood. And there should be an agreed policy on whom to treat as patient once we get the test confirmed. And the cost of case finding should be economically balanced in relation to the possible expenditure on medical care as a whole. So case finding finally should not be a one-time process. It should be a continuing process and not a once and for all project. So these are the criteria that is used even by WHO and throughout the world, which implements newborn screening in their practice. So why does newborn screening matter? If we look around the globe today, more than 70 countries have already newborn screening program in place, and they are testing millions of babies each year with this program. So the impact, if we look at this newborn screening in developed country, newborn screening identifies about 1 in every 800 to 1,000 newborns with a treatable condition. And according to WHO, 5 to 10% of the world population is affected by rare diseases. And now, if we look, the coverage of newborn screening, over 40 million babies worldwide are offered some form of newborn screening with the newborn blood spot screening annually. However, this just represents about 30% of the global birth around the world. And the coverage by region, if we see, USA, they have 100% coverage, Europe 78% coverage, Latin America 32%, Middle East and North America 26%, Asia Pacific 13%, Central Africa 0%. And when we talk about Nepal, we do not have any of these in place. So now let's try to connect with rare diseases. How do we define rare disease? So when a condition is called as a rare disease, we all know it affects a very small percentage of the population because the name itself has a rare disease. But it is important to understand that the definition of rare disease actually varies depending on where you are in the world, because what is considered rare in one country might not meet the criteria or the threshold to be called rare in another country or region. So if you look at the definition of given by the European Union, a rare disease is a disease which affects fewer than 1 in 2,000 people. So this is actually a proportional definition based on the population size. For example, if a country has 10 million people, the population of the country is 10 million, a rare disease would affect fewer than 5,000 individuals. For example, if Japan's population is about 125 million, 1 in 2,500 people affected with the disorder would be called as a rare disease. And in the United States, the definition is based on the total numbers. So any condition that affects fewer than 200,000 individuals nationwide is considered rare. So considering the population of the United States, roughly 330 plus million population, this works out to be 1 in 1650 people. If the condition is affecting 1 in 1615 people, we call it as a rare disease. And if we again take an example of Japan, the benchmark is even more specific, fewer than 50,000 individuals. So now, after the definition, let's look at the global rare disease statistics. So now when we say rare disease, people often think it's uncommon. It happens rarely to very few people, and it does not matter. I mean, it is rare, it is very minimum, and it hardly matters. But the fact is, even though each rare disease on its own affects only a small number of people, when we add them all together, the rare disease affects more than 300 to 400 million people globally. And that 300 to 400 million people is roughly equivalent to the entire population of United States, approximately 4 to 6% of the global population. So imagine the entire United States, the population being affected with rare disease. So while they may be called rare collectively, rare diseases are actually common, and they represent one of the most pressing yet under-recognized challenges in global health. And though individually rare, together they represent a significant public health challenge. So far there are over 7,000 identified rare diseases, and new ones are described regularly. And most rare diseases are genetic in origin. Around 80% are genetic. It could be a single gene disorder, a chromosomal disorder. And though genetic, there are other causes for rare disease like infectious, autoimmune, or degenerative causes. And majority of these rare disease occurs during childhood. Often 70 to 90% of the cases begins in the childhood. And these conditions are often progressive, chronic, and disabling for the babies. So few rare disease examples are like phenylketonuria, PKU, cystic fibrosis, CF, spinal muscular atrophy, SMA, Duchenne muscular dystrophy, DMD. So there are lots of rare diseases in the list, more than 7,000 that has already been, described. Now, if we look at this global statistics, the United States, 25 to 30 million people are living with rare diseases. That is, 1 in 10 Americans actually have rare disease. And if we look at the European Union, the people, 30 million peoples are affected. And in India, it is estimated that 70 to 96 million people may be affected with rare disease, because there is no hardcore statistic from India. So it's suggested based on the population that is there, the high population, 70 to 96 million people may be affected. And if we look at China, 20 million people are living with rare diseases already. And here's the source given down here. So treatment gap, if we look at the treatment gap here, only 5% of the rare diseases have an FDA or EMA, that is the Food and Drug Administration in the United States, and the European Medicine Agency have approved the treatment for rare diseases. And majority of the rare diseases remains without effective therapy. So, and there also remains this diagnosis challenges. There is a term known as diagnostic odyssey when it comes to rare diseases. So it is said that the average diagnosis for a rare disease patient to come up, it might take on an average 5 to 7 years. And this confirmed diagnosis involves multiple specialists, multiple referrals, wrong diagnosis before the correct diagnosis is made. And definitely rare disease patients face higher healthcare costs and out-of-pocket expenses, and family often experience financial strain and psychosocial burden, social stigma, and a lot of emotional toll. Now, let's look in the context of Nepal. Newborn screening and rare diseases. In Nepal, without data and awareness, these children and family with rare disease often remain invisible to our health system. If we look at the newborn screening and rare disease perspective in Nepal, so the health indicators for Nepal, if you see here, the neonatal mortality rate was 17 deaths per 1,000 live births as per the UNICEF 2023 record, and the infant mortality rate was 23 deaths per 1,000 live births as per the same data, and under 5 mortality rate was 26 deaths per 1,000 live births. And we do not know how many of these deaths were due to undetected rare disease. And what if we had newborn screening in place and we could have detected those conditions early? We would have been able to save those lives of the babies, and the death per 1,000 that we have just highlighted here could have been decreased. So in the context of Nepal, the burden of rare disease is mostly hidden. We do not have a national registry, so we do not even know how many children are actually affected. And in regards to newborn screening, there is no newborn screening in place. Although recently screening is available in few, maybe 1 or 2 private hospitals, and pilot studies are being conducted in one hospital that I recently came to know about in Kathmandu. So there are very few pilot studies that has been done in the past, and they have identified, based on those pilot studies, conditions like congenital hypothyroidism, cystic fibrosis, sickle cell disease, and lysosomal storage disorders in babies who were born in Nepal. And the feasibility study demonstrated, exploring the utility and exploring the newborn screening practice in Nepal has demonstrated that the results were delivered to the child within 2 weeks, and parents often prefer the cost-free screening approach, because the screening test, when we go in a private lab, the cost is high, and not all the parents would want to save that expense for the testing. So if we look here, a very small example, children with congenital hypothyroidism, it's not a rare disease. It's simple thyroid disorders, which is very common in Nepal, in other part of the world. And in Nepal, because of the lack of the universal screening program, children are often diagnosed around 6 months to 1 year after some notable symptoms appears in the baby. But by then, there is already the damage that has taken place, and the baby manifests with irreversible intellectual disability. So challenges and opportunities that we can see in context of Nepal: we do not have a policy framework to screen the babies. We do not have government fundings which could keep this newborn screening program into system. We have limited laboratory infrastructure. We do not have a test we do not have proper infrastructure to test for the DBS sample, the dried blood spot sample. There are limited infrastructure and access to health facilities, especially in the rural areas. People have to travel a lot even for a simple delivery. So newborn screening is far, far beyond their reach, their hope. And we need to, the opportunities are that we need to spread our awareness among healthcare providers and parents as well. And the policy should support and fund for essential new national program for newborn screening and diagnosis of rare diseases. And we mentioned earlier that the diagnostic odyssey averages about 5 to 7 years globally, but in country like ours, in Nepal, the odyssey might even be longer. We do not know. And families go through again multiple hospital visits, referrals, and wrong diagnosis. And many parents, they lose their child, their members, without even knowing what the diagnosis was, what the cause for the death was. We see a lot of newborns passing away without their parents having an answer to what led to the death of their baby. And there is definitely high cost, social stigma, and a lot of emotional toll that takes place. So, looking forward, what is the future we can dream for Nepal? Step 1, we need to build awareness and advocate for all levels, including the political levels as well, because until and unless we have the government involvement, just a small institute starting with this program is quite a bit challenged due to numerous reasons. The fund, the infrastructure, everything causes a huge challenge for starting up the newborn screening. And next, step 2, the political and government ownership is needed. We need to start with pilot newborn screening with priority condition, and stepwise implementation approach is crucial step in country like ours. We can start very small, start with 1 or 2 conditions, and then see the benefit, make the system fall into place, and gradually scale up the program. So if we look at the conditions like which could be used, looking at the practice that has been done in India, we can definitely choose conditions like congenital hypothyroidism, G6PD-H deficiency, congenital adrenal hyperplasia, CAH, galactosemia, and biotinidase deficiency, and hemoglobinopathies as well can be screened. And the diagnostic testing of these disorders, they are not very complex. We do not need sophisticated infrastructure to test these disorders, and also the treatment is easily available for this condition, because many rare diseases drugs, they comes in millions of dollars, but for these conditions it's simple treatment that can be just started, and we can save lives of babies. And step 3 would be establishing a national registry to know our numbers and plan better. This could also be helpful for and essential for epidemiology research and policy making. Step 4, advocacy and technical support. We need to engage with WHO, UNICEF, and other agencies who can provide us with the technicalities, with the support, and also with the advocacy of newborn screening and rare diseases. We need to build partnership with government and other global bodies like International Federation of Clinical Chemistry, American Association of Public Health Laboratory, Association of Public Health Laboratory, the International Society for Neonatal Screening. There are a lot of global newborn screening program, the Rare Disease International, there's Indo-US Rare organizations. So all these organizations, when we collaborate with these organization, we would definitely learn from them. We would be able to implement what has been done in other part of the world and try to bring a small portion of it to Nepal and start our program. And finally, developing a comprehensive rare disease care center in Nepal, because when the family can find the diagnosis, treatment, and support under one roof, this really would help and would cover the overall life quality of the person or the baby suffering with the rare disease. So this is the vision that should be made possible for patients living with rare diseases in Nepal. So in in coming to RDSN and the Ministry of Health, it is very good to know that there was a consultative meeting on rare diseases in Nepal, which was organized by the Ministry of Health and Population on very recently, 18th June 2025. And the Ministry of Health and Population Nepal has, for the very first time, engaged relevant societies and experts to develop a formal definition of rare diseases in Nepal and to compile a list of commonly occurring rare diseases in Nepal. And we had our RDSN team members, being a part of this meeting, and RDSM team is honored and pleased to be a part of this committee as well. And we hope that this meeting would progress with a bigger vision and at a speed so that things can get into place sooner. And when we look at the collaboration, the Rare Diseases Society Nepal has been collaborating and is a member of Indo-US Rare Patient Alliance, as a member of Rare Diseases International. We have recently signed a memorandum of understanding with the Hereditary Angioedema Society Nepal, and we are partners with Rare Diseases Bulgaria and other international societies. So now, what do we need to know is screening is just the first step. Screening alone is not very useful without, a confirmatory diagnosis, without treatment in place, and without the follow-up care. Rare disease cares goes beyond diagnosis. Family needs a multidisciplinary approach. There needs to be a team of metabolic physicians, endocrinologists, geneticists, biochemists, dietitian, physiotherapist, and psychologist working all together for one patient who is suffering from rare disease. We also need nutrition and supportive care as often as important as medicine, because most of the conditions you need to plan the nutrition very carefully so that the child does not present or manifest with a debilitating condition. And the patient would need lifelong treatment, and hence supportive care must be ensured. The social security and insurance must be strengthened in providing continuous support to the person suffering with rare disease. And most importantly, patient advocacy group must be empowered, because the patient's voice must be amplified, and because they are the voice of family who live with these rare conditions every single day, nothing would be more powerful than the voice of the patient, than the voice of the patient's family. So how can each of us contribute? The doctors and the health workers can recognize early signs and symptoms, avoid misdiagnosis, and actively advocate for screening. There has been recently a talk about updating the medical education curriculum, where more of these rare disorders are involved, more of these genetic disorder, more of these inherited disorders is planned to be incorporated in the medical curriculum itself. And we also need involvement from the policymaker who can support newborn screening program and rare disease registry formation, and integrate newborn screening into a maternal and child health program across our country, Nepal. Families can and should share their stories, raise their voices, and join very strongly in advocating. And as a society, we must show empathy, reduce the stigma associated with rare disease, create supportive communities, because when it comes to rare disease, silence helps no one. So the overall framework, it starts with awareness, then we advocate for certain condition, things comes into action, but that's not the end. It goes on a vicious cycle in a continuous process. So finally, I would like to conclude with a statement that yes, every baby counts. We call or categorize a condition. A condition can be categorized as rare, but if we look into that one baby with a rare disorder and that one family, what is rare by definition? It means everything. It means 100% for that one individual, that one family with rare condition. And if we detect these rare conditions late, we lose the potential of that individual forever. But if we detect them early, we give them back their future, as early detection prevents disability and they saves lives. And on the other hand, every baby deserves equal chance, not just because they are born in developed country or country with every infrastructure. What about the children who are born poor, who are born in country where there is no infrastructure? Every baby should be given an equal chance to life. Every baby, regardless of where they are born, deserves equal chance at health. Especially, there is a saying, prevention is better than cure. And for rare disease, this is especially true because often there is no cure. And every detection is early detection is the only best strategies to save life, to prevent disability, and to support them. So despite knowing the benefits of newborn screening and its significance in rare diseases detection and management, there is limited broader reach of essential screening. We don't need to go with the rare diseases. Just taking an example of congenital hypothyroidism, which has a very simple treatment of starting a levothyroxine tablet. It's a life-saving potential, a condition with a life-saving potential. Even with such simple, treatable, and detectable disorder, only 30% of newborns worldwide are screened for CH. We do not need that extra infrastructure for it, but the gap you see is 30% of the newborns are just screened, and the remaining 70% are devoid from this life-saving diagnosis and treatment. So I would like to conclude my presentation with a thought that when we save one baby, we save an entire lifetime of possibilities, because every baby counts, every story matters, and together we can create a future where every newborns are screened, where any rare diseases are not ignored, where families are supported, and where every child in Nepal is given a fair chance at life. Thank you very much. I hope this presentation has helped to bring some insight on the topic. And now I would like to welcome your questions, and also in the audience, if there is anyone who would want to share any of their thoughts, perspective, experience in regards to newborn screening and rare diseases in their context, are welcome to unmute themselves and speak. Thank you so much for your time and your participation. The floor is open for questions and discussions, and we are happy to take the questions. And if there are no questions, we would love to hear your experience, your encounter with newborn screening or any of the rare diseases.
Hello.
Yes, Ram Vinod sir.
Thank you, Dr. Bijaya. Thank you so much for your presentation. I have seen that 1 in 17 people suffering from the rare disease. So just I want to know which one is most common for our country.
So that's the problem, sir. For our country, we do not have any registry yet in place. We do not know the prevalence. What are the disorders that are seen around? We don't have an idea about it. So in Nepal, when we are talking about Nepal, we do not know what is the most common disorders that is prevalent in our context. If Rajan sir would like to add something.
Thank you. I have also seen that 1 in 10 Americans suffering from this RD. So in US, which one is common out of 10 rare disease?
I am sorry, I did not look into that, which one is common. But in US, they do have this robust screening into place where there is this term known as recommended uniform screening panel, where they screen for 38 metabolic and endocrinologic disorders, hemoglobinopathy. So there are 38 conditions which are screened. 32 is screened by all the states. 38 is recommended by the RUSP. We call it as a recommended uniform screening panel. And there are 25 secondary target disorders which are screened. So all in all, they screen for, including the primary and secondary, they screen for more than 60 disorders in the United States.
Okay, thank you so much. Just I would like to suggest you, you contacted with the IFCC, this newborn screening task force, this committee
Yes,
for the establishment of newborn screening center in Nepal?
Yes, we did. I did, and we were in contact, and all they want is for a group of doctors, healthcare professionals to come together as a team, including people from the ministry, pediatrician, gynecologist, lab, everyone to come together as a team first. And we did have I got an opportunity to meet the members as well when I went for a conference. And yes, we are planning, and hopefully, it's on the planning phase. In November, the IFCC team is planning to visit Nepal for the newborn screening program, how to go about it. So we are hopeful that something would happen in the month of November. Yet the programs are yet to be finalized, and we would definitely update once things come into place.
Yes, we are going to have an one-day workshop in November.
November 8th.
In collaboration with the IFCC.
IFCC.
Okay, thank you so
I'm
much.
happy to be a part of that team as well.
Thank you so much, Dr. Bijaya.
Thank you, Dr. Bijaya, for your great initiative and nice presentation.
Thank you.
I think people will be benefiting from these presentations, as well as the series of presentations you have been putting online. So it's a great initiative. Whenever I see a small child, I see the future there, because very challenging now with the population being diminished day by day, and lot of pathological conditions occurring in the families. So this great initiative is will be very, very supportive in near future, because there are people who might not have known it, because they might have recognized it just as another type of the problem. But I think very rapidly, sooner or later, it will catch up, and then you will be having a forum for better discussions, and you will be involved in the policy making. All the best. Thank you.
Thank you so much, Lamsal sir. I would like to introduce Lamsal sir. He is my head of department biochemistry here at BPKIHS. And sir has really been supportive in fueling my dream, my passion, and I'm very grateful to the entire department of biochemistry here at BPKIHS for their constant love and support every time. Thank you so much.
Thank you, Dr. Bijay, for this excellent presentation. Regarding this newborn screening, still we are in infancy in Nepal. As you presented in your presentation, there is some pilot program is there. Recently, we started this newborn screening for hemoglobinopathy in various hospitals. Recently,
yes, I would like to yes, I was about to come to that. So Dr. Rajan is also a board member of Rare Diseases Society in Nepal, and he's actively looking into patients, and he's been diagnosing a lot of cases with the rare diseases, and he is also a part of I think WHO, the sickle cell anemia and thalassemia team, and Bheri Hospital in Nepal has started hemoglobinopathy screening for free. And I think this is the first step of actually newborn screening into place. So congratulations, and we would definitely want to learn from you. You would be the pioneer person to help us spread this system into other institute as well. So kindly share your insight about this thing, and we would love to hear from you.
As you clearly mentioned, that we need a national policy and guidelines and this implementation, because without political commitment we cannot progress further. So the meeting, as you showed in your slide, no, this was, I think this was the first meeting regarding in the government level concern about the rare diseases. So main limiting factor is still is commitment, because there has to be something in policy level. As you already mentioned, because this early diagnosis makes lots of difference in life and cost. Because I'm diagnosing many rare diseases, and when I ask them, they tell about they spend about 1 million rupees, 2 million rupees, 3 million rupees. They has sold all their lands. So if you go in the personal and family level, it's really devastating. Not only in our part, even in western part also, as you have earlier shown, they visit multiple consultants before final diagnosis. This 5 to 10 consultation is average consultation before final diagnosis. So now, due to this genetic knowledge and due to this era of omics, all genomics, so I think if we government can implement this genomics in preventive and in screening purpose, in affordable cost or free of cost, many rare diseases will be diagnosed in the early stage, and they can be salvaged or managed or cured or treated. That can be something done. And I liked, as you told, I appreciate that it's not only test, it is a comprehensive care. Just testing is not sufficient. It has to be comprehensive care, holistic approach, personalized approach is important. So I think we have to start from somewhere. We have done from database. Just yesterday only, one of our colleague microbiologist, he sent a report of his son. It is a rare this disease related to the bone. There is a ossificans progressiva. The cost of treatment of that disease is about $1 million per year. So really, the rare disease is very difficult to manage, and it's very expensive. 1 million per year treatment means it's not accessible, not approachable. So there has to be something from insurance level, something from government level. Otherwise, this patient's family or child's family will be victimized, and it will be very painful. And there will be treatment divide. For example, if you have money, or if you are in the first world, you will get all the treatment from insurance, and if you are from third world, then you will be not getting the treatment. So there is a treatment or therapeutic divide. So there has to be universal health coverage for this, not by one. As you told already, even child born in Nepal or the New York or the US has to get the same treatment for this rare diseases. So I think we have to do some this orientation to the member of parliament from somewhere, MPs of the this federal government and provincial government. Until and unless it is done from the policy level, it's very difficult to do in institutional level. So if at least from the RDSN we are doing something awareness, I think it will help in somewhere. And again, I want to thank you for this comprehensive this approach of this newborn screening. I visited 5 years before the SCPGI Lucknow. They are doing this newborn screening from 2015. They have already screened about 65,000 newborn, and they found about 250 rare diseases. They are doing for congenital hypothyroidism, this congenital adrenal hyperplasia, galactosemia, 6-speed deficiency, and biotinase deficiency. They are not doing for immunopathy. They are doing for these 5 diseases from different districts level hospitals. They are taking sample, and they are doing test in SCPGI Lucknow in Department of Medical Genetics. So in Nepal also we have to implement from somewhere, from government level. So this will if you start doing something, then you will have database. Now we don't have database. Which diseases are common? So as you told, at least we can start from congenital hypothyroidism and immunopathy. We can add on later. Again, thank you, Dr. Bijaya.
Thank you so much, Dr. Rajan. And we have a question here, like a suggestion from in the chat group. Do contact NEPAS, that is, I believe, Nepalese Association for Pediatric Society. So we will definitely reach out to them when we plan for the upcoming IFCC event. And in regards to cost with this DBS test, what I have come to know is, like, I was approached by one of the lab from Bangalore. They were wanting to partner, like they wanted to they had visited BPKIHS and we had a conversation, and the cost they highlighted for screening was like on average it came out to be 8,000 NPR for limited disorders that were listed. And even in I think in NPL in Kathmandu, the lab has started with the newborn screening testing, and the DBS test would depend on the number of tests or condition you want to screen. The more disorders you want to get tested for, the cost would go up. But on average, for 5 to 7 disorders, what as per what I know comes around 8 to 10,000. But I need to confirm that with the lab. I'm not very sure about it, but on average, it's 8 to 10,000 for the minimum 5 disorders that we were talking about. But I will definitely reach out and confirm if any parents would want to know about this newborn screening, and they would be saying that I want to pay and get my child tested. At least with this awareness, with spreading things, we need to give them that chance as well. Just because it is not there in the policy, in the system, if certain labs in Nepal, they have started doing the test, although it takes there's certain cost for it. If they want to go for it, I think that should also be kept into place, and that awareness should also be given, because it's always better to diagnose a baby and save a life. Thank you so much for all the questions, all the input. If there aren't any questions, we would like to close the session here. Thank you everyone for taking out your time this Saturday morning and being with us, showing your passion, your interest in knowing about newborn screening and rare diseases. We truly appreciate your presence, and we look forward to all of you joining in future webinars as well. We conduct webinars every last Saturday of the month. So thank you so much. Thank
Dr.
you.
Bijaya.
Yes, sir.
Bijaya.
Yes, sir.
Just I want to know one of our friend is working in Kathmandu University. Who is also the corresponding member of NBS.
Yeah, Dr. Pratiksha. Dr. Pratiksha Gewali, yes.
Are you? She is connected now?
I really do not have any update, because she should be the one who should be connecting with the IFCC task force and then communicating back. But I don't think there has been any update on that, at least not to me.
Oh, so no update. What is going on?
No update to me so far. No update to me. Maybe she has updated some other doctors in Nepal, but not to me. I'm not aware of it.
Okay. I'll talk to
you can
her.
follow up on that as well.
Yeah, I'll follow up. Dr. Rajan Pandey, actually, affiliation of, I want to know the affiliation where he is working nowadays. Rajan, namaste, Dr. Rajan.
I'm working in Bijaya Hospital, Nepal, and I'm a chief consultant physician here and associate professor of internal medicine in Bijaya Hospital.
And sir is doing absolutely wonderful work with diagnosing rare disease patients in the field of sickle cell anemia and thalassemia. Truly so much to learn. I hope someday BPKHS can bring you here for a workshop on diagnosing sickle cell disease and thalassemia. We can really start from there. I truly believe, and your expertise would definitely help the system to fall into place in most of the institute. At least one institute in a province really would want to get that happen. So we will plan that, and we would love to do that. It comes with a lot of constraints for sure, but we will definitely aim for it in the future.
Thank you.
Okay, thank you. Thank you, Dr. Rajan. On behalf of NACC, I would like to invite you right now. Actually, formal invitation will be sent later. So now I would like to invite in the workshop. The NBS workshop
Yes.
will be held in November in Kathmandu. And during the workshop, I think some representative will come from IFCC and APFCB. So during the workshop, you can collaborate with them to establish a newborn screening center in Nepal, either in Kathmandu or in Nepalganj or in BP Catcher. I have seen Dr. Bijaya is investing most of our professional life in this field. So it will be better to establish at least one center now in Nepal, maybe in BP catches. So thank you so much.
Thank you.
Such a wonderful, like it's.
Dr. Rajan, may I add? I thank you for your presentations, Dr. Bijaya, and Dr. Rajan is there who has shared information rightly. Yes, we should have a collaboration. I'd like to share to every one of you there that we had started as a MSc thesis by one of our students, Amit Mishra, who had been working on the sickle cell anemia that time, long time back, and we wanted to do the screening, and we sent him to BHU also, and under the co-guidance of our Professor Dr. Das, he had done some kind of work there, and this has been there, but it's lying there only in the cells. That's whenever you don't have a transformative way, and you don't have a teamwork, and then which can be carried on later on, that will be difficult for the survival, like the children. Why do we see the future in the children is a very important aspect, that one day they will be growing as a young people, and then after that there will be again some generations will grow up, and then they will be having good family members and contributing to the population dynamics. And here also we have got the same problem because of the lack of carrying the legacies of people. Okay, so what I see from the beginning is that you should have the teamwork with the younger people also who can take it to the forefront. Okay, because that's how we can build up a human resource for the future. Okay, so we should plan for the human resource, train them, and build up a center where they can work, and also not only work, because I'm writing here something like you cannot just be a researcher if your stomach is empty and brain is full of your knowledge. First of all, you should have stomach which should be filled, and then there should be some amount of money which should be available. And unfortunately, our NGOs and INGOs only come in the support, and when we depend something on the foreign aspects, one day that collapse like what we have seen with the fate of USAID and other. So why not generate the resources in-house or in country, and then let's develop that one without having to beg from others. Only we can collaborate, but begging will be too much because that will collapse. That's what we have seen. So why not take the opportunity, because we can contribute to knowledge, skills, and also financially also, because there are so many people who are ready to finance, but we do not know how to approach them. So if you can make these kind of programs available in the media or in certain forums, wherever the forums are available, we should approach to them. And then it's not that we can only have a narrow kind of system. If you keep yourself in the watertight compartment, you'll never progress. So you should explore in different kind of forums, be it in the forums of the physicians or in the surgeons or in the orthopedicians or in the nursings. We should go and percolate into that so that they will understand the advantage of this, because they are always encountering this kind of people, but they do not know how to approach, to whom to approach, and what to do later. So this will be a good initiative, but try to build up a resource which is in-house, which will be more stronger than the one where we have to beg. Thank you so much, and all the best.
Yes, thank you, sir. Finally, I want to add, without biochemist, without microbiologist, and without pathologist, clinician's job is just a guess. So I always want to thank our this laboratory team, and I'm especially thankful to Associate Professor Dr. Pragya Gautam. She is the person behind our this clinical success and clinical discovery here. From lab side, always she is doing this work in day and night. So I want to thank all the lab team, pathologist, microbiologist, biochemist, and especially as Professor Dr. Pragya Gautam. So without the laboratory, good laboratory, with clinician and any resources cannot do anything. So we have to invest in laboratory medicine. So I request our seniors also to invest and fund in biochemistry, microbiology, and pathology field. Yes, thank you.
Thank you so much, everyone. And sir, just to introduce, Dr. Ram Vinod Mahto is currently the General Secretary of NACC, and I'm happy that he invited you for the IFCC team. I'm very, very thankful to sir, and I'm sure Dr. Rajan is going to be a great asset for the team. And thank you, everyone, for your time and the discussion. Now, with this, happy Saturday to everyone. I hope all of you have a wonderful day ahead. Enjoy the day, and we would like to request everyone to kindly leave the meeting except for the RDSN members. We conduct our monthly meeting after webinars. So I request the RDSN members to stay online and other participants to leave the meeting. Thank you so much. Namaste, and thank you for joining. Have a good day.